Hello and welcome to PanKind's EmpowerEd webinar, Pancreatic Cancer Diagnosis and New and Emerging Therapies. My name is Sophia Casbolt and I'm the Program Manager at PanKind. Thank you so much for joining us tonight. So November is World Pancreatic Cancer Awareness Month, and as a proud member of the World Pancreatic Cancer Coalition, we are continuing our effort to increase awareness, support early diagnosis and improve survival for pancreatic cancer. We welcome the other coalition members who are joining us tonight, and we look forward to continuing to work with them to raise awareness of this disease. We're also really pleased to announce that in November, we'll be opening a new grant round for collaborative research. So please check that out at our website, pankind.org.au. All right, so I just have a little bit of housekeeping to go through. So I need to let you know that the information presented in these webinars is of a general nature and should not be considered personal or medical advice. Always seek independent advice relevant to your specific situation. The opinions of the presenters are their own and do not necessarily reflect the views of PanKind. This webinar is intended for medical professionals, so please be aware that it does contain medical language and surgical imagery. If you experience any technical difficulties during the webinar, please let us know via the chat bar on the right of your screen or email me at sophia@pankind.org.au. A recording of the webinar will be available after tonight from our website, pankind.org.au, and only those presenting on screen will be in the recording. During this webinar, attendees' mics and cameras will be off. All right, so it's my pleasure to welcome Andrew Dean tonight. Andrew is the Head of Medical Oncology at Sir John of God Hospital in Perth and a consultant for GenesisCare. Previously, he established the palliative care service at Sir Charles Gairdner Hospital and St John of God Hospital in Perth, and was appointed Professor of Palliative Medicine by Edith Cowan University. He flies himself to a variety of rural areas in Western Australia, including Geraldton and Broome, to provide outreach oncology services. He's published articles on symptom control, novel therapies for ovarian cancer, pancreatic cancer, and the molecular profiling of solid tumours. He regularly participates in international clinical trials and continues to be a major contributor of pancreatic, lung, and ovarian cancer studies. Tonight, Dr. Dean will give us an update on the signs, symptoms, and diagnosis of pancreatic cancer, as well as new and emerging therapies. After his presentation, we'll have about 10 to 15 minutes for questions. Please send through your questions at any time, though, via the Q&A panel on the right. And if a question comes through that you'd also like answered, you can upvote it in the chat. Questions most relevant to today's topics or more general in nature will be prioritised. If you have questions that are specific to your circumstances, these are best directed to your healthcare team. Okay, now I'd like to hand over to Dr. Dean to present.
Hello and good evening, and thank you very much indeed for asking me to participate in this webinar about a topic that's very dear to my heart and is my main sort of research focus. So we're going to be talking about pancreatic cancer diagnosis and emerging treatments, and what I'm hoping to do is put a bit of an Australian flavour on it and talk to you about some of the things that we're doing here in Australia and how it's relevant to treatment of pancreatic cancer, and in many ways leading the world in some of the results that we're achieving. So the exact league table of where pancreatic cancer comes is debated, and sometimes some people say it's the 5th most common cancer, some people say it's the 8th. It's probably becoming more common with time. And in Australia, there were nearly 4,000 cases diagnosed so far this year, pretty much equal number of males and females. And it's even though it's not one of the more common cancers, it's the 3rd most common cause of cancer death in Australia in 2020, which is quite a sobering thought. And the current figures based on 2020 suggest that we have a 11% chance of surviving at least 5 years if you're diagnosed with pancreatic cancer, which is, although it sounds fairly dismal, it's a significant improvement from 30 years ago. So when people present, I'm just going to talk about what happens when people go to the doctor for the first time. When people present, the classical teaching is that we're taught that people present with painless jaundice, so they've gone yellow without any obvious reason for it. And I think this distinguishes it from biliary colic and gallstones, which can be associated with jaundice, but usually is also a rather painful thing. You can present with back pain, upper abdominal pain, or unexplained weight loss. And combinations of those symptoms is something which we should be smart about thinking that require investigation. Jaundice in its more simple phase can just be a bit of yellow tinge to the eyes, and this slide's just showing what happens in the early phases of jaundice, where the skin hasn't changed colour, however the eyeballs start to get a yellow tinge to it. And then when that becomes more full-blown and you develop full-on jaundice, it can become a lot more florid like that. So in fact, the whole skin can become quite yellow. That's an indication that the bile ducts aren't draining at all, and will usually mean that people require a plastic tube to be put into the biliary tree, to drain the bilirubin. In terms of people's past history, we always ask if there's any illnesses in the past, and in recent years we've probably noted a bit of an increase in inflammation of the pancreas, otherwise known as pancreatitis, being an initial presenting feature, and that once the initial presentation with an inflamed pancreas settles down, it becomes clear that there is actually a lump sitting deeper in the pancreas. And so people, in my view, who present with pancreatitis from any cause, once that pancreatitis is settled, I really think they should be followed up with blood tests looking at the tumour markers and repeat imaging of the pancreas. If patients have a family history of pancreatic cancer, we know that this increases the risk. If there's a single relative with pancreatic cancer, either brother, sister, mother, or father, means that your own particular risk is 7 times greater than average. And if you have 2 relatives, 2 first-degree relatives with pancreatic cancer, or a grandfather and father, or grandfather and mother, it makes the risk 35 times more likely than the general population. But there is also an association with other inherited genetic syndromes like Lynch syndrome, where people inherit defective DNA, and the defective DNA leads to the development of a number of different gastrointestinal tract cancers. So when somebody walks into the surgery and you examine them for that first time, there's a few different things that we look for. One is, of course, jaundice. Sometimes people look a bit wasted, thin. Sorry, there's a bit of a feedback on the microphone there. People can look a bit pale and washed out. They can look like they've lost a lot of weight. And this particular slide is showing the presence of some enlarged lymph nodes in the neck, which can be felt on palpation. And that's quite a common sight of seeing the first signs of distant spread of a pancreatic cancer, or indeed, in fact, any other cancers. And when you examine people's abdomen, it's rare these days that you find it late, but when you do find it as late as we do, you can feel a lump in the center of the tummy, or sometimes you can palpate the liver. So once we see somebody and we're suspicious that they may have pancreatic cancer, we initiate a number of investigations. Firstly, some blood tests, looking at the blood count, obviously liver function, because we want to see what the bilirubin is and see if there's any derangement of the other liver enzymes. We check for tumour markers, that's CA19.9, which is a protein found in the bloodstream that's made in very small quantities by normal cells, but is made in excess quantities, particularly by cancer cells. And the CA19.9 is associated in high levels with pancreatic cancers and biliary tract cancers. It is a bit of a catch, however, because anything which causes inflammation in the biliary tree, or in fact even in the lungs or the esophagus and stomach, can actually cause modest elevations of CA19.9 although we quote that the normal reading is 37 or less, it's fairly common that you see readings of 300, 400, 500 being caused by things like gallstones. So if in doubt, we always repeat the reading after a couple of weeks. We also check for other tumour markers like the CEA, or carcinoembryonic antigen, and this is not specific to pancreatic tumours, but is a general gastrointestinal tract marker, which can be elevated in a number of different gastrointestinal tract conditions. And then CA125 is more commonly known as the ovary cancer marker, but again, none of these cancer markers are specific. And there was some interesting data presented at a Asia Pacific summit that we went to a few years ago from a surgical colleague in Beijing, and they found some interesting work saying that the presence of a raised CA125 actually was quite indicative of prognosis in pancreatic cancer. So, but that's not something that we've necessarily seen replicated in our own data or that of data within Australia. So once we've done our blood tests, obviously the next thing is take some pictures, and how are we going to image the abdomen, or to look for the presence of tumour. And in simple phases, often ultrasound is one mechanism of doing this. Sometimes patients have a ultrasound looking for a presence of gallstones, and that it turns up an abnormal mass in the pancreas. The gold standard investigation is really a 3-phase CT scan. So if we are seeing somebody for the first time and we suspect that pancreatic cancer could be on our differential diagnosis, then we would request a 3-phase CT scan, where the CT scan is really, you get 3 scans in one. The first scan scans the body sort of top to toe while the contrast is flowing through the artery. The second CT scan is acquired as the contrast passes through the arteries and then through the capillaries into something called the portal vein, which shows up the veins between the gut and the liver, and including the venous flow through the pancreatic area. And finally, there is a venous phase where the contrast is then passed through the liver into the rest of the body. And that is always the most accurate way of seeing if there is a tumour in the pancreas and whether there is any involvement of the blood vessels. And then finally, if we're still having difficulty demonstrating reasons for symptoms or reasons for obstructive jaundice, an MRI scan or magnetic resonance scan of the pancreas, otherwise we requested as something called an MRCP, which is magnetic resonance cholangiopancreatography. So try saying that after 3 gin and tonics. And the MRI scan clearly shows that the biliary tree in the pancreas in a different way to the CT, but it should never be considered as being better than a CT or a replacement for CT, because the CT scan is what gives us the most consistent, reliable and reproducible method of imaging the pancreas, liver, and the biliary tree. So if we see an abnormality present, then obviously we want the sample to see what it can be, because there are lots of different tumours that can be in the pancreas. And for instance, obviously pancreatic cancer, pancreatic adenocarcinoma, which is what we're talking about tonight. Neuroendocrine tumours of the pancreas, which are quite different and have completely different treatment, different prognosis. And we've even seen things like lymphomas of the pancreas, or in 2 or 3 weeks ago, I actually saw somebody who was sent to me because they were diagnosed with what they thought was pancreatic cancer, but when we investigated further, it turned out to be a lung tumour, a lung cancer that actually spread to the pancreas. So getting a tissue sample is always vital, because that really hinges. That's what makes our entire treatment decision in terms of what treatment we're going to use to treat the cancer with. So in the slide that I showed you earlier of the lymph node in the neck, that's a very easy place to get a fine needle core biopsy from. or alternatively, in people who have enlarged livers, liver sample is good. And I just make a point that when, so if you're a GP or another specialist and you're requesting a biopsy, please request a core biopsy rather than a fine needle aspiration, or otherwise known as FNA. And the reason for that is we're doing an increasing number of molecular tests on pancreatic tumours, and some of these tests are for potentially new biological treatments like PARP inhibitors, if people have inherited certain gene abnormalities. And if the biopsy is done with a fine needle, we literally don't obtain enough tissue to be able to test it for all the molecular tests that we need to do. So we always say, look, please can we get a core biopsy rather than FNA, because it gives us more tissue to test. And obviously the more tissue we have to test, the more likely we are to be able to find something that may offer some emerging and evolving treatments. And also, again, being practical, many of the new trials of new drugs, and particularly things like immune therapies and biological agents, they require a core biopsy rather than FNA, because they need the extra tissue to try and match tumor type, the genes present in tumors with the newer treatments that are being trialed. So if none of these biopsy modalities are an option, then we go to what we sometimes regard as the gold standard, which is an endoscopic ultrasound. And what this slide is showing is essentially a bit like having an endoscopy. So that anyone who's had a gastric ulcer or indigestion in the past, who may have had an endoscopy, an endoscopic ultrasound is essentially an endoscope which has got an ultrasound in the tip of the scope. So those of you who can see the pointer on the screen, this is the endoscope coming down through the stomach. And Sophia, is my pointer showing on the screen? Hopefully you can see the pointer there. So the endoscope goes down through the stomach into the duodenum, and using the ultrasound probe, they can see the area that they want to biopsy, which is hidden behind the duodenum in the pancreas. And the biopsy needle comes down through the endoscope and is localized by this ultrasound probe, so they know exactly where to stab the needle through the wall of the duodenum. Because obviously if you look down in that with a normal endoscope, it may all look completely normal, and so it's very hard to then try and biopsy at random through the wall of the duodenum. As if you biopsy down here, you may well just get normal pancreas and miss the diagnosis completely. So what the operator of the endoscope sees is a picture a bit like this, and on the left-hand side here we've got the ultrasound scan, which always looks like looking for a snowman in a snowstorm, but essentially what you're looking for is a disruption in the pattern. So you may see these black shadows within sort of the white snowstorm, and these shadows are what you're essentially aiming at. So you'll see here at the top of the screen that the needle has been passed through the wall of the bowel and is just sampling the top of this mass, which has been seen here in the pancreas. And at the top, this little circle is actually the ultrasound probe. So the ultrasound probe is firing sound waves, and the sound waves are reflecting off the tissue, and hence you see a very straight line, which is highly reflective, which is the needle. But underneath is a mass which has disrupted the tissue planes and is absorbing a lot of the ultrasound waves, and hence it looks like a sort of a black shadow in the middle of the snowstorm. And what you see on CT is a cross-sectional CT where this is the left kidney, the right kidney, that's the liver, and then there's a number of blood vessels around the pancreas, and then you can see there's a tumour sat there within the pancreas. Now, if we were trying to biopsy that through the abdominal wall, obviously it's a long way in, and we've got duodenum we've got small bowel sat in between that. We've got blood vessels in the way. It's not exactly a risk-less procedure to try and biopsy a tumour lump like that. So if you can imagine that you've passed an endoscope down through the duodenum here, you can select the point at which you can biopsy the tumour without passing through the blood vessels that are in the way. So endoscopic ultrasound is really now one of the most important investigations that we use for pancreatic cancer, not just for obtaining the biopsy, but also because it provides a very, very clear picture of whether the tumour is attached to the wall of the blood vessels. And that's an important thing to determine surgical approaches to the pancreas. And what we'll do is we're going to take a closer look at that as we proceed with our discussion. Now, it is quite a reasonable time, actually. I'm just going to take the first question from Andrew. And Andrew, your question, which I'm just going to read out to the audience, is that I have had 2 family members diagnosed with pancreatic cancer. Should I have annual tests for tumour markers? Now, that's a very good question. The simple answer is yes, you should go for screening, but tumour markers themselves are not necessarily reliable, as a number of pancreatic tumours don't make tumour markers. So probably 20% of people with quite significant size tumours have normal pancreatic markers. So there's been increasing interest in using this endoscopic ultrasound technique to assess the pancreas. And so here in Perth, my colleagues who do the endoscopic ultrasound actually offer a screening service for anyone who's had 2 family members with pancreatic cancer. We strongly recommend a genetics referral so that you can speak to the genetics counsellors. You can actually have gene tests carried out to look for genetic abnormalities, including BRCA1, BRCA2, ATM mutations, and a thing called CDKN2A mutations, to name a few. And these are inherited gene faults. And if you have an inherited gene fault, then you know that you're in particular need of regular screening. So if you came to see me for an opinion, asked my question on that, my opinion, I would say to you, yes, you should see genetics, and don't rely on tumour markers alone. I would suggest that you see a gastroenterologist with a specific interest in endoscopic ultrasound, because they will almost certainly offer you a yearly ultrasound test of the pancreas, which will be done under anaesthetic, and that's one of the more reliable ways of picking up early tumours. So back to the topic. So what happens when we found the tumour? Well, we now do something called staging, and people often talk about staging and get misconceptions. And what's important about this is, stage 1, stage 2, stage 3, and stage 4. They're really just methods of communicating a treatment approach to the different stages of cancer. And for instance, stage 1 is generally treated with surgery, usually now followed by chemotherapy. Stage 2 is surgery followed by chemotherapy, occasionally with radiotherapy. And we'll talk about the differences in staging in a sec. And stage 3 is not what we call locally advanced tumours. They're not, you don't operate on those, because by the fact that they're stage 3, you know that they're inoperable. However, there's a lot of data accumulating now on how we can downstage people from stage 3 to stage 2 through the use of chemotherapy and radiotherapy. And I'm going to show you some of our own Australian data on that fairly shortly. And stage 4 tumours really will pretty much never, I say pretty much never, be resected. And you primarily rely upon the role of chemotherapy and occasionally integration of certain forms of radiotherapy in order to treat these. So I'm going to tell you a little bit more about the staging. So stage 1 and stage 2 tumours nowadays, when they're removed with either a Whipple's operation or a distal pancreatectomy, there are 2 forms of chemotherapy which have been shown to improve the survival, and that is chemotherapy with a recipe called modified FOLFIRINOX. And although that's got a reputation as being a fairly difficult recipe to get through, I think as we've gained more and more experience with this chemotherapy recipe, we are much more confident that people can get through treatment with this recipe and still have a reasonable quality of life. And the recipe FOLFIRINOX has been associated with the best improvement in survival for pancreatic cancer that we've seen so far. Whereas there is a more gentle recipe for people who perhaps where FOLFIRINOX is thought to be too strong or too harsh, and if people are fairly frail or if people don't tolerate FOLFIRINOX, there is another recipe called gemcitabine with capecitabine, which has been shown to improve the cure rate, not as much as FOLFIRINOX, but nonetheless it is actually a sufficient improvement compared to no treatment. With stage 3 and 4 tumours, it's a different approach, and there's a lot of discussion about what we use first line and second line. And what this slide is showing is, if you're diagnosed with a stage 3 or stage 4 pancreatic tumour, the prime therapy is FOLFIRINOX or gemcitabine plus nab-paclitaxel. And there's reasons why some centres prefer one, some centres prefer the other. And we developed a lot of experience with gemcitabine and nab-paclitaxel, otherwise known as Abraxane. We gained a huge amount of experience with that early on, thanks to the generosity of the pharmaceutical company that make Abraxane or bring it into Australia. And they gave us an enormous amount of free drug actually to treat people before it had been approved by the PBS. And so, we developed a lot of experience using this particular recipe up front in people with stage 3 pancreatic cancers who had very, very good responses, and we'll show you some of those shortly. Whereas certainly in the public system, the government's currently reimburses FOLFIRINOX, so that is usually the gold standard for treatment of stage 3 cancers up front, in an effort to try and shrink the tumour down to operate on. Now, if you look at the literature, there's probably an equal amount of publications and presentations at all the big international meetings, where you're all extolling the success rates they've had with using FOLFIRINOX up front, other centres using the gemcitabine and nab-paclitaxel up front. And really, there's probably not a lot to choose between them. They both seem to be effective, just that we personally have had a lot more success with the gemcitabine and nab-paclitaxel than has been seen in our same service with FOLFIRINOX. We also have second-line chemotherapies, and so that's for people who don't respond well to the first line. And in particular, if we talk about stage 4, or otherwise known as metastatic pancreatic cancer, the general consensus now is to lead with gemcitabine plus nab-paclitaxel, because this drug, nab-paclitaxel, is only approved in Australia for pancreatic cancer if it's used in the first line metastatic setting. So in other words, if you were offered chemotherapy for a stage 4 pancreatic cancer and you chose FOLFIRINOX up front, then the government will not reimburse gemcitabine plus nab-paclitaxel as a second line therapy. Whereas if you treat people the other way, if you have gemcitabine and nab-paclitaxel up front, the FOLFIRINOX drugs are all completely covered for whatever stage you want in the treatment line. So for stage 4 cancers, pretty much everywhere now should be using gemcitabine and nab-paclitaxel up front. And then we've got the option of other chemotherapy recipes that are shown below for second and third line therapy. And again, that in itself, what I just said, is a somewhat controversial statement, because it was not many years ago that we had a powwow, a get together of everybody who was treating pancreatic cancer around Australia. And when they said, "Oh, what do you use? What do you use third line?" There were blank stares, and people said, "There is no third line treatment for pancreatic cancer." And what I'm hoping to do is to show you our data that we've gathered on third line treatment. So in other words, first line treatment is the first recipe, second line treatment is the second, and then now what we're doing third line. And I want to show you some of the results that we've had with that, which we actually hope are changing the landscape internationally. So some of our second and third line research is now being taken on as kind of recommended gold standard therapy on the international scene. So I'll show you some more of that shortly. So before we get a bit more onto some more detailed information on the staging and the treatments, one of the commonest questions that I get asked is, why can't you chop it out? And I guess what I want to show you, so if you're not keen on seeing any medical pictures, now's a good time to make a cup of tea. But this is the anatomy in the area. So what I'm showing you here is the pancreas, which sat behind the duodenum. So on the previous endoscopic ultrasound picture, you'd imagine that the endoscope would come down the esophagus here into the stomach. In this case, they've shown a tumour in the tail of the pancreas, and that would be, you'd be able to ultrasonically biopsy that through the wall of the stomach. But if you want to interrogate the head of the pancreas, obviously the endoscope has to come all the way down here and biopsy through the wall of the duodenum. You have gallbladder and biliary ducts, you have the pancreatic duct, and this is the problem, is all of these vessels, all of these blood vessels, which are so kind of surround the pancreas and so intimately involved with the pancreas, that when you go to do surgery, you see literally this is an area where this is a piece of pancreas here labelled as pancreas. The tumour that's just been removed is sat right in this spot here, and depending on the position of the tumour, if the tumour is pushing in one way, it can bind to this artery here called the celiac axis or celiac artery. It can involve the artery to the liver, the spleen, the artery that supplies the gut called the superior mesenteric artery, or the vein that drains the blood flow from the bowel back into the inferior vena cava here. And these are all highly important vascular structures which you can't really chop out and remove. And hence, if you imagine that there's a tumour sat in the middle of all those blood vessels, all it needs to do is to fix to one of them, and you can go through a 6 or 7 hour operation and be completely unable to actually get that tumour out. And this is what it looks like after dissection, where you have the main vein that drains the body called the inferior vena cava. We've got the superior mesenteric vein, and the vein that comes in from the spleen, the splenic vein, and they join together. This is sometimes called the confluence, which then the confluence of the splenic vein and the supramesenteric, and that forms something called the portal vein, which then flows off to go down to the liver. And again, this is the area where the tumour can sit and involve any one of those vessels. And really, that's just showing you the arteries that are present in the same space. So all of these veins and arteries are really all kind of all interrelated, and the pancreas sits slap bang in the middle of those. And that's why surgery to try and remove that is notoriously hard work. So what I'd like to do is now sort of really we're talking about, what about outcome from pancreatic cancer? And this is just a schema that I put up looking at global figures and our own figures associated with how it used to be with pancreatic cancer. And for every 100 people who walk through the door, when you do the scans, it seems that about a quarter of those have a removable tumour, the tumour that appears operable. And so out of these 25 people who go to the operating theatre, once they get into the abdomen, again, it can take sometimes 6 or 7 hours of operating. Sometimes it's found that the pancreatic tumour involves the blood vessels, despite the best imaging that we have saying that they were clear. So again, wanting to stress that there is no such thing as an absolute guarantee with any of the tests that we do to determine whether tumours are definitely operable or not. And I think most of the time now our surgeons tell patients going for surgery that we believe that the tumour is removable, but there's always a risk that once we get in, we may find something that means we can't chop it out. But the sobering thought is for those people who do actually have surgery, the 20 people who do have surgery, and there are generally only 4 people still alive at 5 years, which means the 16 people who have had surgery to remove what appears to be a curable tumour, have actually died from this disease. Now, this figure is changing, and that's what the next series of slides is going to be about. But it makes the point that 3/4 of the people we see with pancreatic cancer have inoperable disease at diagnosis, most having what we call locally advanced, but unfortunately a significant group having tumour that's already spread, usually to the liver. And the 5-year survival figures for these numbers are actually really poor. It's very rare that somebody with metastatic, stage 4 pancreatic cancer is actually alive at 5 years, whereas there's a few with locally advanced disease who actually do make it. And that really leads on to the prognosis. And so when you talk about prognosis and so what is the prognosis? And then we talk about, well, okay, it really depends upon the staging, and as it's the staging that determines the treatment, the treatment, the prognosis and the staging are all sort of intimately related. So stage 1 pancreatic cancers, which have the best results, have a tumour that's present within the pancreas, and that the tumour is smaller than 2 centimetres. And it's rare that you find a tumour in the pancreas that small. Usually it's a tumour that's found by accident because somebody has a scan carried out for another reason, such as a back pain problem or a gallbladder issue. And literally, the tumour's found early. It's less than 20 millimetres, and we regard that as a very the earliest possible stage of tumour. If it's between 20 millimetres and 40 millimetres, then it's not spread anywhere else. It's a stage 1B. If the cancer's larger than 4 centimetres, it's a stage 2A. And then if it starts to spread to the local or loco-regional lymph nodes, then it becomes a stage 2B. And so the staging is really just kind of trying to tell us where the tumour is, which then helps us to try and plan the treatment approach for that. But obviously, as the stage goes up, it means that the tumour is more advanced, and that the risk of there being metastatic spots that have already spread, so in other words, tumour cells that have spread and floated off in the bloodstream, that risk is clearly getting bigger as the stage goes up, which means that there is in fact a later tumour. And then stage 3, which is what we might call locally advanced, it's to do with whether the tumour is attached to any one of those blood vessels that we saw before. And you'll see in this diagram the tumour is attached up here to the celiac artery, and down here it may be involving one of the superior mesenteric arteries or veins. And that's whether it is or isn't in the nodes. The fact is the tumour is attached to the blood vessels, and that means that it's not immediately operatable on. And again, that just shows this is where the tumour sits, and where the blood vessels are there to get involved. These CT scans are really showing the same picture, and the bottom quarter of the slide here is showing the relationship between the pancreas and the blood vessels that we've just been looking at the pictures of. And if we cross to the right, you'll see that the head of the pancreas, which sits in front of the inferior vena cava, which is shown here, and you'll see that the head of the pancreas is right against the blood vessels called the superior mesenteric vein. And if we look on this schema here, you'll see that here's the tumour. You can see it's wrapped around the superior mesenteric vein. It appears to probably be free of the superior mesenteric artery, and there's the aorta there and the inferior vena cava here. So that tumour would be considered inoperable by virtue of the attachment to the superior mesenteric vein. And then finally, of course, when we talk about staging, stage 4 pancreatic cancer means that the tumour has spread to other parts of the body, and most commonly that's the liver. And cells can fall off the pancreas itself into the abdomen, into the peritoneal cavity, and obviously can spread through the bloodstream to end up in the lungs as well. This is what liver metastases look like when tumour has spread via the portal vein into the liver, and all of these the white things all represent tumours that are burrowed into the liver, and you can see that there's no surgery could ever remove all of those individual spots. They're always widespread, and preceding this, before you could see all this scattered tissue, there would be a multitude of tiny spots that really, little things like this that you're not going to be able to see, and little things like this that you're not going to be able to see on CT scans or ultrasounds. And that's the risk with pancreatic cancer, is that it spreads so quickly. So when we look at life expectancy by stage, you'll see that if people have what they think is an early cancer, so stage 1 or stage 2, and you have surgery only, the cure rate is only about 10%. Whereas using simple chemotherapy like gemcitabine does produce some improvement in that. And then we spoke earlier about gemcitabine and capecitabine, which it produced a significant improvement over the original treatment of single-agent gemcitabine, which came out in the 90s. And of course, nowadays we have the latest recipe, which has been so successful in the Prodigy study, which has shown a marked improvement in what we call progression-free survival and overall survival. And when that data matures, we're projecting at the moment that this will probably be approximately 45% of people who've received surgery followed by the FOLFIRINOX recipe. We're expecting about a 45% cure rate. In terms of, I think we touched upon this before, and really this is going to just a little bit more detail. And it's just that the FOLFIRINOX is the gold standard, and if we compare it to gemcitabine on its own, the average time for relapse of people that get gemcitabine is about 12 months. It's 22 months with the FOLFIRINOX, and what we call median overall survival, which is the average survival time after this treatment is past the 4-year mark. And obviously, when we talk about median survivals and average survivals, this is, this means that the 50% of people do better than that, and it's the 50% of people who do better that are the ones who are, more likely to be cured. Because if you don't have relapse, if you're disease-free by 5 years, generally it's extremely unlikely that you would relapse subsequently. One of the big debates, and it's something which we were supposed to be hosting our national medical oncology meeting this year here in Perth, but due to apparently there's a virus doing the rounds that has somehow interfered with those plans, so our meeting in fact didn't go ahead. So I'm rather hoping that next year we'll be able to have the same meeting, the same discussion. And one of the big discussion points is if you find an early tumour, perhaps it might be not quite touching the blood vessels, there might be a few lymph nodes involved. Should people go straight to surgery? And obviously there's a strong yes that says, well, you should, because you can resect it while you can. And if you can chop it out now, then potentially you've got better local control. But there's also a counter argument to that, which says that When you find the tumour, there's significant risk that there are already seeds that have spread to the liver. So if you have surgery and you have an uncomplicated recovery and start your chemotherapy quickly, hopefully you kill those seeds in the liver before they take root. But if you have a long recovery time or a complicated recovery time, then by the time you get to start on what's supposed to be your adjuvant chemotherapy to increase the chance of being cured, the tumours may well have already taken root, and consequently the results much worse. And there's a lot of debate about this topic at the moment, but we probably, in a nutshell, really say that people with early tumours where you can resect them, if you can resect them with confidence, you should probably get on and do it quickly. But there are also studies that are ongoing looking at treating people with chemo first, because the people who progress rapidly following surgery are probably the people who would have best benefited by having chemo up front. So, that's another whole debate which we may get onto we might be able to get onto that one in some of the discussion. And there's a sort of an in-between phase where you might say it sits somewhere between stage 2 and stage 3. And it's approximately a third of people who walk through the door have a tumour that compromises partially at least one blood vessel. And literally you only need a little bit of shrinkage to make it operable. And so the vast majority of people with so-called borderline resectable tumours will now be offered chemotherapy. And, generally, probably, I would say at least half of these ultimately go on to be resected. But, there's always a risk that if you operate, you go through a 6-hour operation and can't remove it. And if you don't operate, that the tumour could potentially grow and involve the blood vessel more by the time the decision is made to try and proceed for surgery. So there are multiple arguments, and there isn't necessarily a right one, other than saying that the risk of you operating on borderline and finding it's worse than what you think is probably significantly higher than any chance that it will be better than what the imaging shows. And this is just a typical example of the modern era of chemo. And this was a patient of mine in 2009 who, this is the CT scan which is showing a view straight up and down. So the head's at the top of the screen, here's the heart, and here's the liver, there's the stomach, and there's a huge tumour of the pancreas that was wrapped around all of the blood vessels, was completely inoperable. And this lady was the first lady outside America to receive nab-paclitaxel for her pancreatic cancer. And this was the same thing 6 weeks later with a massive reduction in the size of the tumour. That lady is very much alive and well today. She's now 11 years since she had an inoperable pancreatic tumour. And it makes the point that just because things are inoperable doesn't always mean that ultimately you can't get good long-term disease control. And we've already touched on that. For the interest of time, I just wanted to show this other case. This was a lady who'd had surgery to attempt to resect this big pancreatic tumour, which is interesting because the tumours are completely encircling at least 2 blood vessels. If you look at this, all of this is tumour. And if you look on this, you can see that this tumour here is literally surrounding all these different blood vessels. And so not surprisingly, the surgery was unsuccessful. However, after having 6 months of chemotherapy with the gemcitabine and Abraxane, she was successfully operated on, and all of the tumour had actually died off to give something that we call a complete pathological response, which obviously resulted in a very good outcome. And we ended up actually publishing our data. A group of us got together back in 2012 and presented our data to the ASCO annual meeting, which I think was the first time that this topic had been presented, and it was treatment which was really pioneered here in Australia, of treating people with this combination of drugs and reporting successful resection of completely inoperable patients. Probably just worth mentioning that there is a lot of discussion about the role of radiotherapy for pancreatic cancer in the curative setting, and we know that if you give people old-fashioned radiation, it doesn't really work very well and can be fairly harmful. However, the newer studies with all the fancy new radiation machines are showing clear benefits in terms of reduction of local recurrence of pancreatic tumours. So we definitely encourage people to seek a radiation oncology opinion from a radiation oncologist who's experienced in pancreatic work. Now this slide here just shows when we integrate radiotherapy and chemotherapy preoperatively. So if we have somebody with inoperable tumours who receive 6 months of chemo up front, followed by radiation, and then go on to surgery, that the overall survival for this is 51 months, which is actually a really, really impressive figure. And this is showing that of 68 people that we found who were with unresectable pancreatic cancer, so stage 3 tumours, who had 6 months of chemotherapy, then radiation, were then, of these 68, 20 people were actually able to have their successful pancreatic resection, and at least 50% of them were still alive at beyond 4 years. And a number of these people have actually never ever relapsed, which is obviously fantastic news to then be cured from what we call locally advanced disease. I'm just going to finish off by saying I'm just going to talk about new things. And metastatic pancreatic cancer, this is shown here with the lesions centered within the liver. Globally, the survival that's quoted is between 3 and 6 months without treatment, 9 to 12 months with treatment. Our Australian data is way better than that for a number of different reasons, and I'm going to go straight to that actually, which talks about how is Australia doing. And in Lancet Oncology last year, there was a publication in September, 18th of September, that showed that Western Australia has the best survival in the world for cancers of the pancreas, stomach, ovary, and colon, and that this study looked at Australia, looked at Victoria, New South Wales, and WA, Canada, Denmark, Ireland, New Zealand, Norway, UK, etc., and looked at cancer outcomes. And in fact, Western Australia had a 5-year survival of 15.2%, closely followed by New South Wales and Victoria. And this gave Australia as a whole a 14.6% 5-year survival compared to the global 11%. And people ask, well, why do we do so well? And I think, firstly, believe it or not, the government actually funds drugs for us really quickly and really sensibly, so it makes good drugs available to us very quickly. But also, Australia's been very active in terms of research and looking at what drugs we give and when. And this shows our Western Australian survival of pancreatic cancer that is advanced stage 3 and 4. And our data is that people with the locally advanced tumours have an average survival of 34 months compared to the global 12 to 18, and 19 months for metastatic disease. That's obviously average survival compared to 9 to 12 months. And there's a couple of different reasons as to why that is. And one of which is that we actually reported, we were the first people globally to report the use of the recipe FOLFIRINOX as a second-line therapy. So this was after people had failed gemcitabine and Abraxane. And we initially made our first case reports of this at the World GI meeting in 2014. And we recently updated our survival to show that our survival figures, to show that of the 85 people in our study group, including 64% who had stage 4 cancer at diagnosis, for those who were well enough to receive second-line chemotherapy with FOLFIRINOX, the average survival was 46 months. And of that was, that was actually 68 months for locally advanced tumours, which is over 5 years, and 23 months for metastatic disease. And again, that when I talked about third-line chemotherapy before, we've now gone to using gemcitabine plus nab-paclitaxel, not just as our first-line therapy, but if people go on to second-line therapy with FOLFIRINOX and fail, we then go on to third-line therapy and retreat people with the first recipe. And again, people who are well enough to go on to the third-line therapy it had extremely good prolonged survivals relating to to sort of third. So I just want to finish off now with one very interesting new drug which we've just completed a trial with, and this is just showing one of the issues we have with pancreatic cancer is that the fluorescent green is actually chemotherapy drugs that are trying to penetrate the tumor, and you can see the tumor's all dark because one of the issues we have is that the drugs don't penetrate the tumor very well. So this is a test done using what we call a fluorescent etching agent, and essentially you have a mouse that you give therapy to. Sorry about the feedback. And if you then use a special computer technique to remove the fluorescence from the circulating chemotherapy, you see that literally all of the drug in this particular mouse, there's the mouse's pancreas shown here, and all of the drug is removed by the etching technique. If you use SEND, which is a drug which hijacks a feeding protein in the wall of the cancer cell, it actually enables the drugs to penetrate the tumor and penetrate them well. And you'll see here that when you give SEND plus the same chemotherapy and then you use the etching agent, you can see that the drug has been deposited in the pancreatic tumor, showing that the SEND is really enabling the drug to penetrate deeply. And again, this is just a schema where the fluoro green is showing the fluorescent chemo, and this is without SEND on the left, with SEND on the right, and similar thing with a colorectal tumor on the bottom. And so we reported this at the recent ESMO European Society of Medical Oncology meeting. And the thing that we really want to show you is this thing called a waterfall plot, where this middle line here is what we call the baseline. So this is the size of the tumor when it was diagnosed. And this is showing either the growth of the tumor, which goes up. Each of these individual bars represent one person. And of course, if it goes up, it means the tumor grows. And if it goes down, it means that the tumor is shrinking. And when you see a waterfall plot like that, where all bar 3 patients have had reduction in the size of the tumor, a lot of them very, very significant reductions. That's something that's very, very impressive. And the Australian GI Cancer Institute, we're working with the Australian GI Cancer Institute now to progress this trial into what's called a phase 2 trial, where we're hoping to build on this results, and hopefully we'll see this is an exciting new treatment that's going to change the prognosis long term. So I'm sorry if I've droned on a little bit longer than what I expected to, and I hope that you have enjoyed the topic or found it interesting, and I look forward to handing over for any questions. So thank you for your time.
Thank you. That was so great. So we do have a few questions. So somebody asked, who conducts tests for tumour markers? Saying that GPs aren't necessarily always educated about this. So how do you go about getting a tumour marker test?
Well, one is to simply just say to your family doctor, either I'm in follow-up for a tumour, or I've had 15 family members with certain tumours, and could I have my tumour markers checked? Now, that it should never be regarded as a good one-off test, because a tumour marker by itself is so completely irrelevant. For instance, appendicitis can give you a significantly raised CA125. It can be as high as certain ovarian cancers can give. So you always want to put the tumour marker in the context of the clinical situation. And that's something that hopefully if you have a concern with that, your family doctor or your treating specialist can discuss that with you as to why it's appropriate or why it's not appropriate to measure a tumour marker in your particular case.
Okay, thank you very much for that. Somebody has also asked about, so previously you mentioned getting scans if you have relatives who have pancreatic cancer. So somebody's just asked if age is a factor in that. So if you're quite young, should you still be getting annual scans, or is there an age-related factor to getting those scans?
Can Can you hear me okay?
Yeah.
Yep. So again, if you're young, you generally want to be avoiding what we call ionizing radiation. So you want to be avoiding repeated CT scans when you're in your 30s and 40s, and even preferably in your 50s. So the scans which do not involve ionizing radiation are endoscopic ultrasound, which is it is an invasive procedure. It requires a light anesthetic, but if you are particularly high risk, your gastroenterologist or upper GI surgeon or oncologist can actually advise you as to whether that's a good technique for you. But endoscopic ultrasound doesn't use any ionizing radiation at all. It's just using reflected sound waves and is perfectly safe. And in other cases where perhaps that may not be suitable or possible, the MRI scans, so what we call the MRCP, the magnetic resonance scan, that's another method of looking at the pancreas in reasonable detail, but without using ionizing radiation.
Okay, thank you for that. Somebody asked, what are your thoughts on the ALAN protocol?
Sorry, I have no idea what you're referring to.
Okay, Susan, maybe if you can provide us a little bit more detail on that, we might be able to help answer that question. Somebody else has asked about if there's any movement in utilising artificial intelligence for early detection of symptoms.
That's interesting, and there has been quite a collaboration with IBM Watson to name just one kind of artificial intelligence platform, and it's quite interesting, because one of the big topics that we were planning to talk about at the MOGA meeting, the Medical Oncology Group of Australia, one of my plenary topics that I wanted to have was a whole session about artificial intelligence and using artificial intelligence, obviously for detection, screening, and as well as treatment. So there's a huge interest in it, and I think there's a lot of different collaborations going on. And I was hoping to be able to enlighten everybody about it in August until a certain virus popped up.
Well, hopefully we'll hear more about that soon then. Is there sort of movement in using it in patients, or is it all sort of in trial at the moment, or just early stage research?
Well, I think there's a lot of collaboration with anonymous data, because obviously nobody's going to share personal data, but de-identified data, and putting it into diagnostic pattern detection. I think it's fair to say that there are studies now in multiple different cancers looking at it for detection, screening, and also for treatment decision making as well, because you could argue that artificial intelligence may remove personal biases from the data, but there's always the problem that the artificial intelligence sometimes doesn't have that gut feeling that you get with a combination of experience, good results, horrific side effects, and just the experience that you accumulate over years and years of treating this. So I mean, I'm actually really excited by what it may hold, but at the end of the day, do you really want to walk into a doctor's surgery and have a robot produce the probe and tell you what you do and don't want, or do you actually want to have a rational discussion with your doctor about why you might want to do something? Because often it's not a straight put in the data and you get a yes or no answer. It's you put your data in and you discuss your risks and concerns, and sometimes very subtle symptoms, and the experienced medical practitioner that you see will kind of assemble from that a balance of probabilities and discuss those probabilities with you in relation to what treatments you can, or what the options are, and it might be options for screening, options for diagnosis, options for treatment.
Yeah, it'd be really interesting to see what comes of that. So we have a few more questions if you have time. We're running a little bit late, but if you have a few more minutes to answer a couple more questions, Andrew?
Sure.
Yeah, great. Thank you. So there's been a couple of questions here. Are there any treatments for people who have surgical cure and have finished chemo?
So, in other words, is there anything that you can, I guess I would read into that, is there any possibility of maintenance treatment? Do you think that's a reasonable interpretation?
I think that's, yeah, reasonable, yeah.
Yeah, so I think generally, you have your surgery, you have your chemotherapy, hopefully with 12 cycles of FOLFIRINOX, and hopefully you get through relatively unscathed and still with a sense of humour. If there was evidence in pathology of tumour invasion into any of the local nerves, or if the resection margin was what we call a very close resection margin, in other words, when you've done the surgery to kind of cut around the tumour, you haven't got a really clear rind of normal tissue, then obviously that's when we start to, in our practice, we do tend to discuss the role of radiation, and that radiotherapy to the resection bed and the lymphatic areas. We believe that makes a significant contribution to reduce the risk of local recurrence. And it's just that the cancer cells, if the margin is very close, there's always a risk that there may be a few cells caught in scar tissue. And in particular, if the tumor cells grow into the nerve sheaths, they can kind of creep up those nerve sheaths. And the problem is that things like chemotherapy drugs don't necessarily penetrate scar tissue and nervous tissue very well, which is why we tend to then talk about giving radiotherapy. So with people who are regarded as at risk, those are the ones who we would always then discuss potentially, radiation.
Thank you for that. So I did get some clarification about that protocol that was mentioned earlier. So they were asking about treatment with intravenous alpha lipoic acid and low dose naltrexone.
Right. So alpha lipoic acid has been around for a while as a treatment for neuropathy, and some people feel that alpha lipoic acid actually does help peripheral neuropathy, which can be associated with certain chemotherapy. Associated with some of the chemotherapy drugs that we use, and that's one of the, I'm sure it's one of the banes of our lives, let alone the banes of the lives of people who are actually going through it, with neuropathy. But I'm not aware of it having any sort of anti-cancer actions, and we have our own peripheral neuropathy prevention strategies that we have with everyone that we have on chemotherapy. So, there's some interesting new work in a drug called PEA, it's actually a fatty acid called palmitoylethanoyl amide, and it's not found in the body, but if you take an excess of it, it appears to help repair some of the neuronal damage, or at least certainly prevent worsening of the neuropathy. So we have a trial protocol currently with the Australian Gastrointestinal Trials Group, or GI Cancer Institute. We're hoping to be able to launch that trial where we can prove whether or not PEA actually works to prevent neuropathy, and we're hoping to have that up and running next year.
That's great. That's actually answered another question that we had about anything on the horizon for neuropathy as well. So that's fantastic. And there's I think that's most of the questions. I'm aware that we are running a little bit late, so I'm really sorry if we haven't quite got to your question. But perhaps we should leave it there, Andrew. So I know we've gone a little bit over for tonight.
Yeah, my apologies. Apologies for perhaps banging on a little bit, but it is one of my favourite topics, and I think it's just so important that pancreatic cancer is often the poor relation of all the other cancers, and it seems to get the least attention, the least funding. And I'm obviously a massive fan of PanKind for the work it does in trying to promote the cause and to raise awareness that pancreatic cancer is a disease with a really poor cure rate, and we're all working as hard as we can to try and change that. But the amount of funding that pancreas cancer gets in comparison to the other big cancers is actually relatively really poor, and that's something that I think PanKind is doing doing a fantastic job in trying to fix that inequality. So thank you.
Thank you, and thank you so much for your presentation tonight, Andrew. It was really informative and really interesting, and no problem about the time. I think everyone's really enjoyed it, so thank you for that. And thank you everybody else for attending tonight. We really appreciate it, and we hope to see you at our next webinar. So thank you everybody, and good night.
Good night.
Good night.